This is a great quote from Dr. Kim Williams, past president of the American College of Cardiology. I recommend a plant-based diet because I know it's going to lower their blood pressure, improve their insulin sensitivity, and decrease their cholesterol. This is where we are in the Bronx at Montefiore Health System. The Bronx is arguably the least healthful inner city in the US. Nobody wants this title. There are 62 counties in New York State, and the Bronx is number 62, last place in regard to health, and it's not even close to 61. So this is where we're based. So it's a challenge and it's a privilege to be able to, help people or help groups that need help, frankly. And one question that I got and I talked about recently at the American College of Cardiology is how in our system, we many years ago got our system to offer plant-based meals for inpatients that you could order in our electronic medical record system. And now it's different, now that there's a law in place, at least has to be offered. It's in California, New York. I don't know that if it's been done anywhere else. And of course, the Physicians Committee for Responsible Medicine, PCRM, has played an integral role in getting those laws passed. And so they asked me, how do we move this mountain? Well, there's physician interest, and many of you in this audience. There's righteous indignation, and we're doing so poorly with dietary health in the US. There's endless sources of righteous indignation, and being a friendly pit bull with a plan. And this is that study by Bundy that we talked about, where 0.7% of the US has a healthy dietary pattern, an ideal dietary pattern. All right, lots of room for righteous indignation there. So we wrote an article called Creation of Inpatient Plant-Based Program, published in the International Journal of Disease Reversal and Prevention. And we really meant it as kind of a how-to, to adapt to your system. And we had a 6-step plan. And the first step is to get an interdisciplinary team. You need a physician lead to drive it. You need to involve your director of food services. That person knows about billing, about intricacies of how your particular system makes food. Different systems make it and store it differently. You need the director of nutrition who can be sure you're following governmental mandates for various nutritional needs, et cetera. And some hospital systems outsource to big food companies, and you would need your liaison to that company if you wish to go down this path. Step 2 is you would develop recipes with nutrition. And to be frank, I just sat there with nutrition and we went back and forth and we made recipes. We have a week's menu of breakfast, lunch, and dinner. You want to have a multidisciplinary meeting to refine the recipes, to be sure they're ethnically and culturally relevant, to be sure they're appropriate in terms of a cost perspective. That's a big deal, obviously, for health systems. And then you want to have some tastings to optimize the flavor and presentation. And we did that. We're like, okay, this is good, this is bad, I'll keep on changing it. And it's come out, I think, pretty good. And while all this is going on, you want to work with your electronic medical record team, I think, for 2 things. One is to get a name for it. And some of them, our system has a character limit. So we call ours cardiac plant-based. And you want to be sure that the order is in a very easy place to find. Like initially ours was like 3 you go on diet and it's like 3 subfolders down. It's like hard. But now it's on the very first line. So you just want to remove the friction. Step 3, patient education. Of course, we should all be doing this every day. Some degree of discussion with patients regarding the importance of a healthier diet for their care. We have a handout that we can give patients. And we're very fortunate. We have the documentary film, Forks Over Knives, that plays on continuous loop on one of the inpatient channels with Spanish subtitles. That they can watch whatever they want, but they could also walk in the patient's room and put this on. It's a wonderful way to help outsource the education, because as you all well know, when you're fielding phone calls and rounding on 25 patients and you have residents and fellows, you can't spend 40 minutes speaking with each patient about diet and lifestyle. There just is not enough time in the day. And this is the same slide. Every little bit counts. I don't expect that we're going to fully change someone's life, diet with a 2-day hospital stay, but we want to plant a seed. Every little bit counts. We want them to know that their doctors think it's important. Step 4, staff education. You want to have staff lectures and small group educational sessions on the diet. Support from nurse managers on each floor is helpful. Outside speakers, like for example, when you're going to kick off your program, you can have someone who could give a grand rounds or something on diet and lifestyle and also promote the program that you're doing, help get the word out, leverage your internal communication systems, your emails, newsletters. This one, I have an asterisk, required practical video. I have not been able to get Montefiore to do this. And I'd love if they did. In medical systems, it's like herding cats. Residents come and go, doctors, nurses, team members all come and go. But they have to credential and they have to re-credential. And there are lots of videos that we have to watch as part of that process. And I'd love to create even just a 6-minute video that's required at credentialing and re-credentialing. So everybody sees it. And it's 3 minutes about why eating plant-based diet is healthy and 3 minutes about how you order it. This is where you click. This is what it looks like. This is what you get. And you want it to be short and simple because no one likes watching these videos. But at any rate, I have not been able to get Montefiore to do that, but other systems are putting such things in place. And tastings for staff are helpful. You want to, when we started the program, I rolled it out hospital-wide. I don't think that's a great idea. Our system is huge and it gets a little unwieldy. I think piloting it on a single floor is great, so you can plan, do, study, act, and make it better. Like the first day, we had cow's milk come up with it. So, there's just a learning curve with it. And then you want to evaluate it objective and subjectively. One thing subjectively that we found is that a plant-based diet looks a lot different than some of our patients are used to eating. And that would turn people off. And so what we did is we asked the PA or nurse or resident who's ordering food to go into the patient's room early on in their stay, like, as they're getting checked in or just after. We're going to be giving you healthy food to help protect your heart. That's it. And then at least they know the food's important and they're primed for something healthy. And I wouldn't use the term, we never use the term vegan. That's not just necessarily health related. You can be vegan and very unhealthy, as you know, and that term is, has ethical and other things with it, which can be very lovely, but it also turns some people off. So I'd recommend not using that term. We've had people be very frustrated when someone inadvertently used that term. At any rate, just having them say that little comment has been very helpful for us in terms of getting people to be happy to eat or willing to eat the diet. So you want to, and another idea is keep things simple. There's lots of opportunities if you keep it simple. And one of them is leveraging your EMR. One thing that we do is I've, quote, mandated it that our cardiology fellows, so we have a pretty big cardiology fellowship program. I think it's like 11 fellows, general fellows a year. That's one of the biggest in the US. And I mandate it so they have to, in their consult notes, does the patient consume at least 5 servings of fruits and vegetables daily? Yes, no, deferred. They have to answer it. And we put this right above the assessment and plan, so it's good real estate and people will be more likely to see it. And we do this, why? So the patient knows it's important, the fellow knows it's important, anyone reading the note knows that cardiology cares about it. And, then our trainees leave. They go all over the world. And hopefully they'll take these themes with them. And one other one that I just started doing is for the physicians in the audience. We often use the term GD, M as in Mary, GDMT. That's short, guideline directed medical therapy for heart failure, GDMT. Use it all the time. And I started to do GDN, N as in Nancy T, GDNT. Why? That stands for guideline directed nutrition therapy. And I write it out so no one thinks I'm making a typo. And because what it does, and I'll say guideline direct GDNT, please order a cardiac plant-based diet. Because what it does is it gives it the diet, the imprimatur, the significance, the weight of guideline backing, which it has. just like guideline-directed medical therapy for heart failure, there are American College of Cardiology guidelines about health, diet, and nutrition, and it's eating lots of vegetables and fruit. So there's guidelines behind it. So why don't we throw the weight of that evidence behind it in our note to, make it, give it that inventory. Anyway, so I just started doing that and playing with that. So there are 3 key ingredients, 6-step plan, keep it simple. We just this past year made something called the Cardio Nutrition Podcast. It's through the American College of Cardiology. It's about 15 short bite-sized lectures, 10 to 20 minutes on different dietary topics. We talk about the guidelines with Dr. Kim Williams. It's really a great one. He also touches on COVID and diet. We talk about different dietary patterns, Mediterranean, keto, plant-based, etc. And it can be found anywhere where you get podcasts. So that's it. Yep. Thank you very much.